Good afternoon, all of you. We are moving on to the next session, that is Frontline Tactics Handling Anterior Segment Emergencies. So, anterior segment ocular emergencies encompass a range of urgent conditions that require prompt evaluation and management to prevent vision loss and to minimize the potential complications. Here, in this IC, our focus is on elucidating the immediate management protocols for common anterior segment emergencies from a general ophthalmologist point of view. So, our goal is to equip the participants with the knowledge and skills necessary to effectively address some of these urgent situations. So, our first speaker is Dr. Aisha PAP. She is the consultant cornea and refractive surgeon at Srikanth Eye Care Hospital, Calicut. She will be talking on corneal catastrophe, responding to chemical injuries.
Good afternoon, everyone. So I'll be mainly talking about the chemical injury, in that the acute or the emergency management of chemical injury. So we all know the chemical injury is one of the true ophthalmic emergency, which often results in ocular morbidity when it is not treated in a proper way. Alkali injuries are more common and can be more dangerous than acid injury. Coming to the epidemiology, 2/3 of the affected cases are mainly seen in the young males, especially in the age group of 20 to 40. And same way, 2/3 of the affected cases are mainly seen in the workplace, especially in the industrial laboratory workers, construction workers, agricultural workers, sanitizing or cleaning crew members. Alkali acid attacks are more common than the acid injury. In India, common are firecrackers, lime, sometimes accidental injury with holy colors. Nowadays, it's also seen with this automatic battery acid burns, which mainly consist of a sulfuric acid, hydrogen, and oxygen. When we are charging, what happens? This explosive gaseous material comes out, which causes one of the important causes of chemical injury. Etiology, we all know, two type, alkali and acid. In ammonia, this is mainly seen in the fertilizers, refrigerants, cleaning agent. Lye in the drain cleaners. Lime, calcium hydroxide, mainly seen in the plaster, mortar, cement, whitewash. This is the most common cause in the workplace. Lime actually has a poor penetration when compared to the other alkali agent, but toxicity is increased by retained penetration time. Acid substances, sulfuric acid commonly seen in the car batteries and industrial cleaners, hydrochloric acid in the chemical laboratories, and the chromic acid, which is an intermediate in electroplating. Why I specifically mention acid and alkali like ammonia, sulfuric acid, car batteries? Because none of the patient come and say I had an acid attack or an alkali attack. Most of them come and say I had an exposure to the car batteries or a chemical laboratories. Based on that, we should classify into the acid or an alkali pattern. Coming to the pathophysiology, I'll briefly explain. When we have exposure to the acid, what happens? It damages and precipitate the protein. This causes the coagulation of the protein and barrier. Actually, this barrier doesn't allow the acid to penetrate inside the eye. While coming to the alkali, this is all a lipophilic substances. This causes the saponification of the cell membrane, causes lysis, causes the enzyme activity will be increased. Thus, the penetration of alkali will be more when compared to the acid. That is why alkali attacks are more dangerous than the acid attack. It actually goes inside the eye, affect the lens, anterior chamber, trabecular meshwork, and causes more complication. So what is the immediate management? A patient is coming with chemical injury. The first step is take the patient to the emergency OPD. The initial thing is the thorough wash. In the wash, which solution we have to take? How we should do the wash? How long we should do the wash? Always the solution should be more compared to the osmolality should be more compared to the cornea. Avoid using tap water because this is a hypotonic solution. So whenever you use the tap water, the chances of corneal edema will be more. It can be either 0.9% normal saline, ringer lactate, balanced salt solution, buffered borate. In that buffered borate, the ideal one, we call it like a polyvalent amphoteric solution. Why? Because it binds to the both alkali and acid in an equal way and it doesn't cause any exothermic reaction. So ideal choice should be always a diphoterine, balanced salt solution, then comes the ringer lactate, then comes the normal saline. But which is available in emergency OPD? If it is a normal saline, we should start with normal saline. Don't wait for the BSS or RL. So I'll show one video of the demonstration of the wash. So ideally, when a patient comes in the emergency OPD, the set should be ready. You should have a kidney tray, and the most important thing is the pH strip. Sterile buds, speculum, and the important one is the solution. So when a patient comes, counsel the patient that we no need to worry, put a drop of paracaine, check the pH, always note the pH and start irrigating from nasal to the temporal side. Ask the patient to look down and up and start irrigating. Keep irrigating for 10 to 12 minutes. Check the pH. If pH is not balanced, always important step is invert the eyelid, check for any debris matter. Minimum 15 to 30 minutes of irrigation should be done. You can use about 1 to 3 liter and always check the pH 15 to 20 minutes. Whenever the pH is neutralized up to 7 to 7.2, you can stop the saline wash. Next comes the history and assessment. Always take a detailed history. Ask the patient what was the solution, what was the concentration of the solution, how was the impact force, what was the volume of the solution. Then comes the slit lamp examination. If it is white cornea, you have to be worried, that is total limbal ischemia will be there. If it is congested also, you have to look for the limbal cell. Always examine the other eye also. Do a fluorescein staining and check for any epithelial defect. If it is a child, always do the examination under anesthesia. Then comes the classification of the chemical injury. We have a 4 types. Based on the slit lamp examination, we are classified into Hughes classification, modified Hughes-Roper-Haar classification, Duas classification, and McKinley's classification. So what is the importance of the classification here? Why are we doing classification? The main importance is to know the prognosis and the outcome, to know whether it is a acute wise or a chronic reaction, chronic attack. Always stick on to the one classification. Don't stick on to 2 or 3 classification. The best one is the Duas classification, because here we are taking only 2 clinical findings. One is the limbal involvement and 2 is the conjunctival involvement. Grade 1 and 2 always has a very good prognosis, because the limbal involvement will be up to 3 years and the conjunctival involvement will be less than 30. Where 3, 4, 5 has a 4 and 5 has a good to guarded prognosis, and the 6 has a very poor prognosis. Based on the classification itself, we can explain to the patient what are the chances of complication might occur in the early reparative or a late reparative phase. This is a picture where in the A, you can see there is only epithelial defect, that is grade 0 and 0. There is no any limbal or a conjunctival involvement. Whereas in the B, it is a 7/60. There are 7 clock hours of the limbal involvement is there and 60 clock hours of the conjunctival involvement. And the grade C, there is a total limbal involvement and the 80% of the conjunctival involvement. So what are the aim of a treatment? The main aim should be to promote epithelialization, to prevent corneal melt, control IOP and inflammation, and to prevent cicatrization. So in the acute phase treatment, the most important step is the promote epithelialization. The best one is the first thing is artificial teardrops. Use preservative teardrop. It helps to reduce the persistent epitheliopathy, reduces the recurrent corneal erosion, and always it accelerates the visual rehabilitation. Bandage contact lens also do the same thing. It helps in basement membrane regeneration and enhances epithelial stromal adhesion. Cycloplegic we can use. It reduces the pain. And AGM, whenever there is any increase in IOP, you have to consider Timolet. If it is not controlling with drops, you have to think about the oral and AGM also. Prophylactic antibiotics to reduce the infection, and steroid. Here's comes the role of steroid. You can immediately, when the patient comes in the first 7 days, you can start the steroid 1% prednisolone acetate based on and the dosage should be based on your grading of the injury. What are the drugs that supports and repairs minimal ulceration? Here comes the role of vitamin C. So what does this chemical injury do? It mainly damages the ciliary epithelium. Thus, less collagen is produced. It decreases the aqueous humor, ascorbate aqueous humor, decreases fibroblast collagen synthesis and inflammation. So we can use 10% topical ascorbate or oral vitamin C, oral tetracycline and collagenase inhibitor. When coming to the early reparative phase, this is the phase that comes after 1 week. Here the complications are mainly chances to come. So if epithelium is not intact, epithelium is not healed, you have to immediately stop the steroid. This is the phase where the corneal ulceration starts and continue other medicines. In the late reparative phase, this is the phase, if it is grade 1 and 2, everything will be healed. But grade 3 and 4, complication goes like ectropion, entropion, symblepharon, corneal scarring. This phase you have to think about conjunctival or tenones advancement, amniotic membrane transplantation, therapeutic penetrating keratoplasty, and tissue adhesive. In the rehabilitative phase, inflammation, everything is reduced. So our main aim should be to give the vision to the patient. If there is a severe corneal scarring, we can do limbal cell transplantation, PK, and keratoprosthesis. To conclude, I would say we need a thorough and immediate evaluation and intensive treatment. Always understand the pathology, explain to the patient if it is acid and alkali, if it is grade 5 and 6, explain what are the chances of the complication to the cup. So our goal should be to restoration of the normal ocular surface anatomy and lid position, control of the glaucoma, and restoration of the corneal clarity. Thank you.
Thank you, Dr. Aisha, for that detailed presentation. Now I invite Dr. Irshad Edavana. He is the Associate Professor and Cornea Surgeon, Malabar Medical College, Calicut. He will be talking about piercing peril, managing the penetrating injury with an hyphema.
Thank you, Dr. Rashmi, and thank you, Rashmi, for the opportunity. So I'm going to talk about the management of penetrating injury with hyphema. There is very less literature that mention how to manage a patient with both hyphema and penetrating injury. We all know how to do manage hyphema or when to intervene in a hyphema. So I'm discussing some topics and some important information. Okay, so as we know, hyphema and trauma most commonly occurs in males and usually in the working class population and home, work, or other sports or recreational activities. Most of this penetrating injury will be because of the projectiles or sharp objects, sometimes because of the fall in the elderly population. So when we see a patient, we have to first evaluate the patient's complete assessment of the eye and as the patient as a general and do the investigations. So as we know, the most important investigation is a CT scan, because in penetrating injury we cannot do a B scan immediately, and to rule out the foreign body most of the time you have to do a CT scan, and then identify the posterior segment fractures or any injury and plan accordingly and explain the prognosis to the patient in the first visit only and need for further follow-ups. So first test in the serious test is important for any small perforation if you doubt any leakage, and measure IOP and dilated fundus examination if possible, always gonioscopy in the later stage. So timing of surgery, most of the time we have to do as early as possible. Risk of expulsive hemorrhage and tissue desiccation should be there. So we have to counsel the patient for a general anesthesia. All penetrating injury most preferably should be repaired under general anesthesia. And during the surgery, do a minimal touch with do not use antiseptics like providone iodine directly to the eye in a penetrating injury, and drape should be done by the surgeon only. You have to be very careful while giving the drop, otherwise there will be expulsion of the content of the eyeball, as we know. So whenever there's a penetrating injury with a hyphema, so primary or management priority should be a stabilization of the cornea and suturing of the wound initially, and then do the wash of the blood. You can just so for example, this case was a 90-year-old female. She came after a fall, so the SE is full of hyphema and there is a wound what we can see from superior limbus about 2 o'clock to 10 o'clock. After the conjunctival exploration, the wound was like about from the 9 o'clock to 2 o'clock. So this type of wounds we cannot suture immediately without forming the anterior chamber. So carefully what we have to do, make a side port incision, make a paracentesis. So in shallow anterior chamber, if you want to make a side port, try to pinch the limbus in the same area. So usually we make a side port by pressurizing the glove from the opposite side. Here you have to just hold the tissue close to your paracentesis and make a slow side port and control side port and put some saline or visco or air just to form the AC. If it's a completely collapsed AC, then form the anterior chamber with a viscoelastic. Then start suturing the wound. After that, once the globe is stabilized, we can do the wash of hyphema. So in corneal wound repair, our goal should be a watertight globe, then wash the hyphema, anatomical restoration, and then functional restoration. Regarding the suturing, as we know, the number of sutures actually depends upon the length of the suture. Each long suture will give a compression half of its length. So when you make shorter sutures, make more number of sutures. if you try to make a long sutures, we can actually reduce the number of sutures. Always pass the needle 90 degree, go almost 90% of the depth, and then come out. As we know, 1 millimeter both side of the wound, and 90 to 95% of this depth of the wound, and equal on both sides. And most of the wound will be oblique or shaved. In these types, always you remember one thing, as you have to pass the needle through the shaved side. That means posteriorly the wound should be opposed tightly, equals. So this side should be equal. Anteriorly you don't have to make the equal bites, but posteriorly it should be equal bites. Then it will not override. Always make shorter sutures in the central area. Try to make the longer sutures in the periphery. When there is a prolapsed tissue, be very careful. In this type of large penetrating wound, there will be a lot of structures that will be coming outside. Try to excise as minimum as possible, but excise the tissue at the corneal plane. Don't try to excise anything inside the eye. Try to repose it. If there's an epithelium, just to remove the epithelium, try to repose it always. If it is devitalized or contaminated, you can just cut the iris if required. So as we mentioned, try to make the side port initially. Try to insert some visco and slowly swipe the tissue inside and start to suture. Just form the AC suture. After that, wash the hyphema. So once again, use long sutures in the periphery, tight sutures. In central closure, apply shorter sutures, spaced to preserve steepening. And if you have, always better to check the intraoperative keratometry to see the astigmatism. And you can use some adjustment nodes for the tightening. Then if it's a long injury from cornea to sclera, always first stabilize the limbus, then go with the cornea, then scleral side. So hyphema we can wash by using Simcoe or using IA port. Never use vitrectomy in a very severe vitrectomy port in an immediate period, because most of the time clot will can be removed with the help of Simcoe or IA probes. Using vitrectomy probes, the issue is that especially in penetrating injury, when the globe is open and even after suturing, sometimes we accidentally cut the other tissues. So be gentle in initial wash. So we can actually wait for some time after the wash. If its IOP is very high and there's a rebleed, you can intervene later also. Don't try to completely wash in the immediate setting, especially in a penetrating injury. Postoperatively, as we know, antibiotics, steroids, etc. should be given. You have to watch for the IOP since there is a hyphema also, and check for the retina and do a base scan in the later period, and gonio in the later time. So key takeaways: evaluate for a proper management, adapt up according to the injury, and always tell the patient regarding the follow-up and need for the long-term follow-up and anticipated complications. And we have to arouse public awareness regarding the prevention of these injuries by school programs or workplace initiative or media outreach. Thank you.
Thank you, Dr. Irshad, for this informative talk. Next, we have Dr. Reshmi S., who is a consultant refractive and phacosurgeon, Eye Foundation Hospital, Kozhikode. She will be talking on hypopain handling.
Good afternoon, all of you. I will be talking about hypopain handling, the differentials and strategies for the effective management. So we know that hypopain, this corresponds to the sedimentation of WBCs within the anterior chamber, and it signifies severe intraocular inflammation. The basic pathophysiology is the leakage of proteins and WBC from the inflamed blood vessels. The causes can be many. Non-infectious include uveitis like HLA-B27 and Behçet's, iatrogenic conditions, medical agents like rifabutin, surgical causes, chemical mechanical injuries. Infectious conditions include exogenous and endogenous infection, and sometimes neoplasms like leukemia, lymphoma, melanoma, etc. So, for the diagnosis and management, we need a careful history taking followed by a meticulous systemic and ocular examination. So, history taking, we are all well aware of. About the systemic history, ask about skin, hair, nail changes, oral or genital ulcer, urethral discharge, fever, neuropathy, etc. Coming to the ocular examination, there is an elaborate naming and meshing system for the classification of hypopyon and pseudohypopyon. A variety of parameters are mentioned in this. I will go through the important ones only. So basically in this talk, we will be differentiating between hypopyon and pseudohypopyon. Based on the formation, hypopyon can be spontaneous as in HLA-B27 or provoked as in the case of a trauma. Pseudohypopyon is always spontaneous. Based on visibility, it can be classified as macro, micro or angle. The first image shows a macrohypopyon that can be seen with the external eye. Second image shows a microhypopyon that can be seen on slit lamp examination, and the last image shows the hypopyon that can be seen in the gonioscopy. Based upon the orientation, it can be horizontal, layered at 6 o'clock as in HLA-B27, or it can be vertical or oblique as in a bedridden patient. Pseudohypopyon can also be horizontal or vertical. Based on shape and position, it can be board-shaped in fungal end-off, convex in microbial keratitis, pyramidal in fungal keratitis, ring-shaped in meningococcal end-off, and inverse in infectious scleritis. Pseudohypopyon can be lumpy wavy type in tumors and inverse type in siliconoid patients. The first image shows the lumpy wavy type in retinoblastoma. It's a pseudohypopyon. Second is yellow hypopyon in a contact lens-induced ulcer. Third one is a triangular hypopyon in microbial keratitis. Fourth one is a panophthalmitis patient. And the lower image shows a board-shaped hypopyon in fungal end-off. And the last one shows inverse hypopyon in infectious scleritis. Based on the color, hypopyon is commonly white in color as in HLA-B27. It can be pink without hyphema in serratia. Candy cane, that is a mixture of hypopyon and hyphema in viral infections. Dark pigmented with melanin hypopyon is seen in listeria and serratia-induced end-off. Pseudohypopyon is usually dirty white in color as in mets and primary tumors. Crystalline white is seen in post-IVTA patient. Yellow colored with cholesterol crystals are seen in cholesterosis bulbae. Brown color with hemolysis is seen in Gaussian glaucoma. Blood tinged with tumor cells seen in intraocular lymphoma. And black with melanoma cells are seen in primary and metastasis. The first image shows a brown hypopyon. The second one shows crystalline white in IVTA patient. The third one is a blood tinged hypopyon. The lower images show black hypopyon and yellow hypopyon. Based on mobility, hypopyon can be shifting within minutes in Behçet's disease and non-shifting in HLA-B27. Pseudohypopyon usually show shifting within seconds. This is the characteristic mobile hypopyon in Behçet's disease. In the sitting position, it is horizontal. On head tilt, the hypopyon is also tilted to one side, and on complete head tilt, it becomes vertical. Based on scleral show, it can be warm or cold hypopyon. Warm hypopyon means there is circumcorneal condition along with AC reaction, as in HLA-B27. Cold hypopyon means AC reaction without circumcorneal condition, as seen in post-IVT and tumors. The first three images show some amount of circumcorneal condition with hypopyon, that is a warm hypopyon. The lower images, it shows the right and left eye of the same patient. We can see that it's a completely white eye with hypopyon in one eye, so it's a cold hypopyon. Based on laterality, it can be unilateral alternating in HLA-B27 and non-alternating as in after IVT patients. Bilateral, symmetrical and non-symmetrical are seen in rifabutin patients. Based on location also we can classify. It can be layered within the cornea as in keratitis. Usually it's seen in the anterior chamber. Double hypopyon can be seen both in cornea, anterior chamber and sometimes within the capsular bag. Subretinal hypopyon means inferior exudative RD with inflammation of subretinal space. This image shows a hypopyon within the anterior chamber as well as within the capsular bag with an endothelial plaque. Pseudohypopyon usually mimic hypopyon in uveitis when it is in the anterior chamber. It can be within the capsular bag in Propionibacterium. Lactocreminacea is a milky white fluid collection within the capsular bag because of the occlusion of the anterior rhexis opening. It is seen in phacoanaphylactic end-off. Pre-retinal pseudohypopyon seen in syphilitic vasculitis and intraretinal one is seen in Best dystrophy. Subretinal in prolymphocytic leukemia. So the first image shows a milky white fluid collection within the capsular bag. The second image shows intraretinal pseudohypopyon in Best disease. This is the pre-retinal pseudohypopyon and the last one is the subretinal one. Based on the purulence, inflammatory hyperpion consists of exudates, proteins, and necrotic debris, while suppurative hyperpion contains some amount of pus cells also. It is seen in corneal infections. Non-suppurative hyperpion is seen in herpetic infections, and non-inflammatory one is seen in metastasis. Based on the onset, we know that it can be classified as acute and chronic, and based on the pathology also, we are all familiar with. Based on the course, it can be transient, that disappear after treatment, seen in IVTA patients and HLA-B27. Persistent can last longer in metastasis and primary tumors. So coming to the next part, that is systemic examination of the patient. The type of inflammation, if it is acute and sudden onset, look for associated factors. If there is arthritis, back pain or GI symptoms, etc., it can be seronegative arthritis. Check HLA-B27 and X-ray sacroiliac joint. If there is associated aphthous ulcer, it can be Behçet's and go for HLA-B5. If it is post-op or trauma patient, it can be end-off and check a vitrectomy. If it is medication-induced, it can be rifabutin, and if it is idiopathic, it can be HLA-B27. On the other hand, if it is a moderate severity of pain and redness with some amount of shortness of breath and subcutaneous nodules, think about sarcoidosis, check ACE, lysozyme and chest X-ray. If there is increased IOP with some amount of central iris atrophy, it can be herpetic iritis. If there is poor response to steroids and manifestations of secondary and tertiary syphilis, check VDRL and FTA-ABS. Also, if it is a post-op patient, it can be endophthalmitis. It can be medication-induced like latanoprost. If there is history of HIV or if there is exposure to TB, etc., check for purified protein derivative, quantiferon TB gold and chest X-ray. If it is a chronic type of inflammation in a child, especially with arthritis, it can be JAA. Check ANA and ESR. If there is heterochromia, diffuse stellate capes, it can be Fuchs. And if it is post-surgical, it can be low-grade end-off also. So in some patients, we may need to go for an aqueous tap to check for the PCR and cytokine biomarkers. The indications include atypical clinical appearance, recurrent uveitis of uncertain etiology, therapy refractory cases, immunocompromised or older patients, limited fundoscopic examination. So to conclude, a careful history taking, detailed stepwise slit lamp and systemic examination can help in 70% of diagnosis in the case of a hyperpion. Detailed evaluation of sediment is indicated in some patients only. So with these points, we can identify the etiology and initiate proper treatment in a hyperpion patient. Thank you.
Thank you, Dr. Rashmi, for this wonderful talk.
Our next topic is orbital ODL, navigating the management of cellulitis, and the speaker is Dr. Soumya Narayanan. She is the consultant oculoplastic surgeon and visiting consultant in multiple hospitals in Calicut.
Good afternoon all. So you have heard about few of the ocular emergencies. So what will be your diagnosis when you see a patient with this picture? The patient has severe lid edema, erythema, proptosis, extraocular movements restriction, diplopia, pupillary abnormalities. And when we check, patient can have an increased IOP, raised retrobulbar resistance. So what will be your diagnosis? First diagnosis, orbital cellulitis. So by definition, infection of the soft tissues posterior to the orbital septum is termed as orbital cellulitis. And Chandler's classified the cellulitis of eye into 5 groups. The group 1 including the inflammation only to the anterior to the septum, and group 2 is the orbital cellulitis. Group 3 onwards is the complications. Group 3 is the subperiosteal abscess. Group 4 is orbital abscess, and group 5 when it is going beyond the orbit, that is the cavernous sinus thrombosis. So by etiology, the most common cause is the spread from the periorbital structures, mainly the paranasal sinus. Then it can be due to exogenous causes like trauma, foreign body, and endogenously can be due to bacteremia with septic embolization. Intraorbital spread can also occur in case of endophthalmitis and dacroadenitis when it is spreading beyond the posteriorly. So in children less than 9 years of old, aerobic and single organism will be the cause. In children more than 9 years of old and adult, polymicrobial, anaerobic and aerobic bacteria, fungal or mycobacterium will be the cause. So most common cause of orbital cellulitis is Staphylococcus aureus and Streptococcus species. The fungal pathogens can also be there. You can see a septate fungus here. That is the mucor, and this is an septate fungus Aspergillus. Both these things, fungal pathogens will affect the immunocompromised patients, and we should check for the skin, mouth, and nose for any black scar. So for evaluation, you should see for the signs like redness, edema, ptosis. The skin can feel warm to touch. Pain can be elicited with either touch or eye movements. Examination of the nose, mouth, and skin lesions will suggestive of fungus infections, and the systemic status of the patient should be checked. So when we evaluate, we should check for vision, any decrease in vision, color vision. The measurement of the proptosis is very important for monitoring the patient. Should check for pupillary abnormalities, ocular motility, and direction of the displacement of the globe is very important, because if there is a subperiosteal abscess, it will push the globe in the opposite direction. And if the patient have a bilateral involvement, always think maybe the infection will be spreading to the cavernous sinus and through retrograde to the other eye. And IOP should be monitored. Fundus examination for optic neuritis and any retinal venous occlusion should be ruled out. So first we have to differentiate between preseptal and orbital cellulitis. So when the infection spread to the orbitals beyond the orbital septum, it can produce proptosis. And when it affects the extraocular muscles, we can have pain with extraocular movement and ophthalmoplegia. And when it affects the optic nerve, vision impairment and pupillary abnormalities will be there. So when in doubt, we should always order for imaging. And in first case, you can see the hyperdense areas are more anterior to the orbital septum, and there is also a ethmoidal sinusitis. In the second picture, you can see most of the hyperdense areas are in the posterior to the septum, and the sinusitis is also present there. So CT is the imaging of choice. In MRI, it will be recommended in children to avoid radiation, and also in when we are suspecting cavernous sinus thrombosis or any intracranial complications. Imaging is warranted in all cases of childhood orbital cellulitis, poor response to intravenous antibiotics, and confirm the presence of any complications. So in the CT, you can see the patient have in the right side proptosis. There is increased attenuation of the periorbital fat and also infiltration of the postseptal fat. You can see hyperdense areas here. And there is a crescent-shaped soft tissue mass near to the lamina papyracea in the medial part of the orbit, indicative of a subperiosteal abscess. And opacification of the orbit of the ethmoidal sinus is also present, suggestive of the cause. So this is a contrast-enhanced fat suppressed T1 weighted MR image. You can see right proptosis, heterogeneous enhancement of the orbital fat here, and ethmoidal sinusitis. So complications also can be picked by the imaging. So here there is a meningeal enhancement suggestive of meningitis. There is swollen and non-enhancing cavernous sinus, and also you can see a narrowed internal carotid artery here. So differential diagnosis, the first one is the orbital inflammation. It can be also mimic as neoplasia, trauma. All these causes can mimic orbital cellulitis, systemic disease, thyroid eye disease, and caroticocavernous fistula. So always we will be confused whether it is a orbital cellulitis or it is a orbital inflammation. So orbital inflammation is a diagnosis of exclusion, and the features suggesting of orbital cellulitis are a history of sinusitis, trauma, or recent history. And the fever will not be present in orbital inflammation. In the blood workup, you can, if you get a neutrophil predominant leukocytosis, that is more favoring of orbital cellulitis. On imaging, both can appear as a diffuse inflammatory process, but sinus pathologists will direct more towards orbital cellulitis. And in case of MRI diffusion weighted image, we can see orbital cellulitis will restrict the diffusion less than the orbital inflammation, because orbital inflammation is more cellular and orbital cellulitis is more of edema. So for management, admission to the hospital is a must for IV antibiotics and for monitoring. Initiation of broad spectrum IV antibiotics that addresses the most common pathogens, and we will modify the antibiotics according to the blood culture and nasal throat swabs. So third generation cephalosporins are our first choice. If it is not controlling, we can also add a penicillinase resistant penicillin. If we are suspecting anaerobic organism, if you should add a clindamycin or metronidazole, there will be gas in the image in the CT. In MRSA infection, we should start vancomycin, and if there is improvement in 48 hours, we can shift to oral drugs. So treatment of sinusitis along with this treatment is very important. We can take an ENT help, either medical or surgical drainage is important. So when we are admitting the patient, we should monitor the vision, any deterioration, any increase in proptosis or chemosis, pupillary involvement, worsening of symptoms, and if the patient is having severe headache and altered sensorium, always think of intracranial complications, and systemic compromise should be seen. So corticosteroids in the management of orbitocele is always a debate, but there are many studies suggesting the benefit of corticosteroids, like reduction in duration of the antibiotics, length of hospitalization, and incidence of abscess drainage. There is less pain, periorbital edema, fever, and chemosis if you are treating with corticosteroids. And there are studies showing at 12 weeks of follow-up, less residual proptosis and restriction in the extraocular muscles, and no adverse effects. But with all these things, when you are starting corticosteroids, we should also think of it can mask the clinical course and allowing the infection to progress by immunosuppression. So in case of subperiosteal abscess, we can observe with intravenous antibiotics if the child is under the age of 9 years and there is no intracranial or frontal sinus or dental abscess and there is no vision loss. And in case of orbital abscess, we should always drain. And in case of subperiosteal abscess, if there is intracranial extension, optic nerve compromise, clinical deterioration with antibiotics and suspicion of an anaerobic infection and recurrence, we should always drain. And what the pus, we should send for culture and susceptibility testing to tailor the therapy. The dangerous complication is the cavernous sinus thrombosis. Even though incidence is very less, the mortality is high. So it's related to the thrombophlebitis in the ophthalmic vein, and sometimes it spread through the valvulus upper and lower ophthalmic vein, and also sometimes due to systemic infection leading to a procoagulant state. So we should suspect it when there are some more symptoms like headache and systemic toxicity than orbital signs. Early diagnostic imaging with contrast will help us, and multidisciplinary approach with a neurologist and ENT should be done. And the treatment entails broad spectrum antibiotics, anticoagulation, surgical drainage, and sinus surgery. So early diagnosis and treatment is a must in case of orbital cellulitis, and close monitoring and detection of complication also very important. Thank you.
Thank you, Dr. Soumya, for that informative and elaborative discussion. Now the next topic is early management of acute angle closure glaucoma, and the speaker is Dr. Soumya PP. She is the consultant cataract, refractive and glaucoma surgeon, Trinity Eye Hospital, Palakkad.
Thank you, KSOS, and thank you, Reshmi, for this wonderful opportunity. Let us go through this. Rapid response. Early management of acute angle closure glaucoma. Before going to how to manage this, let us know about what is angle closure glaucoma. Angle closure glaucoma is a group of disease in which there is reversible, maybe appositional or adhesional, that is cynical closure of the anterior chamber angle. The angle closure may occur in an acute or in a chronic form. Classification, it may be primary or secondary. Primary, it can be classified as acute and chronic. So, what are the terminologies that you usually see? Primary angle closure disease and primary angle closure glaucoma. What is primary angle closure disease? It is narrow angle AC and there will be apposition. But what happens in angle closure glaucoma? There will be optic disc changes as well as visual field defects will be there. These are the risk factors, demographic as well as anatomic factors. Age 60 to 70 years, gender male to female, that is female is more predominant. And anatomic, the short axial length, shallow AC, iris lens diaphragm placed anteriorly, plateau iris, narrow angle of the anterior chamber, that may be smaller eyeball, bigger size of the ciliary body, smaller diameter of the cornea, large lens, anterior insertion of the iris, many more. So coming to the pathogenesis, it may be pupillary bulk mechanism, that is major, that is 70%, phacomorphic mechanism, that is 20%, plateau iris configuration. Pupillary block mechanism, what are the precipitating factors? The patient may come with like reading in the dim light, watching TV in the dark room, sympathetic overactivity, even anxiety and emotional stress, or pharmacological mydriasis. What are the drugs? We have to inquire the patient that whether the patient is on any phenylephrine, tropicamide, cyclopentolate, homatropine, atropine, any tranquilizers, bronchodilators, antidepressants, vasoconstrictors, or any pharmacological meiotic drugs like pilocarpine. And these antidepressants, anti-Parkinsonism agents, antispasmolytics and sympathetomimetic agents are also causes. What is the mechanism? There is mydriasis, there is mid-dilatation of the pupil. There is not fully dilated, mid-dilatation, and there is increased opposition between the iris and the lens, and there will be a relative pupillary block which causes aqueous to collect and push the iris anteriorly, which causes an iris Bombay. Like this, and the contact of the iris with the cornea, and that is called oppositional angle closure, and there is increase in the IOP, and the chronic state, it causes a formation of peripheral anterior synechial and causes the synechial angle closure. In the meiosis, there is contraction of the ciliary muscles and the zonules relax and the lens move forward, and there will be contact on the iris with the lens. And this is plateau iris. What is plateau iris configuration? Insertion of the iris anteriorly on the ciliary body or displacement of the ciliary body anteriorly, opposition of the peripheral iris. This is plateau iris configuration. You can see in this, there is a normal anterior chamber and there is a plateau iris, double hum sign. Coming to the major classification, how will you, the patient will come as a clinically based classification, latent primary angle closure, subacute or intermittent primary angle closure, acute or chronic. But it is again reclassified. There is primary angle closure suspect, primary angle closure glaucoma. So we can classify as primary angle closure suspect as latent PACG or a primary angle closure, subacute or acute, that we will be dealing mostly. How will you manage the acute? The primary angle closure glaucoma, that is the chronic type. What is PACS? How will you identify this patient is having PACS? There won't be any symptoms. We will be identifying the patients while we are doing a glaucoma screening program usually. So there is a Van Herring's grading system that you all know. And the diagnostic criteria is gonioscopy, iridotrabecular contact without a PAS. The major thing that you have to remember is IOP will be normal, optic disc as well as the visual field will be normal. Angle is at the risk. And what are the clinical cause? What had happened to it? IOP may remain normal. It may go to acute or subacute angle closure or even go to the chronic angle closure. What is the treatment for this? Without treatment, risk of acute pressure rise during the next 5 years is about 50%. So we have to treat this one also. How will you treat this case? If one eye had an acute or subacute angle closure, then fellow eye should undergo a prophylactic PI. If both eyes have occludable angles, laser PI may be done. Coming to the PAC, there will be acute asymptomatic quiescent PAC going to PACG or subacute or acute PAC. In the gonioscopy, there will be iridotrabecular contact, IOP will be elevated, plus or minus PAS, and optic disc and visual field defect will be normal. Angle is abnormal either in function, that is either IOP rise or in structure if PAS is there. Subacute PAC in the form of pupillary block glaucoma which may not have been recurrent symptoms. These are the symptoms. Patient usually present with ocular discomfort or frontal headaches. Attacks are recurrent, are usually broken after 1 to 2 hours by the physiological meiosis. What are the signs? During an attack, eye is usually white in this case. In between the attacks, eye looks normal although the angle is normal. What the clinical cause? It may go into an acute attack or into a chronic angle closure. In this case also, what the treatment? Prophylactic laser PI is the treatment for this one. Coming to the most important thing that I am dealing right now, that is rapid response acute PAC. The precipitating factors will be pupillary block, sudden closure of the angle, attack of the rise in IOP, does not terminate on its own, and it is a sight threatening. What is the symptom? The patient will come with a sudden severe pain, nausea, vomiting, may have a rapid progressive impairment of the vision, very red eye, photophobia, and lacrimation. So these are the signs that you have to look in this patient. The lid may be edematous, conjunctiva chemosed and congested, cornea will be edematous and it will be insensitive, AC will be shallow, and the angle of the AC completely closed on gonioscopy, iris is discolored, pupil semi-dilated, vertically oval and fixed and non-reactive to light or accommodation. IOP will be between 40 to 70 usually, and if you see the optic disc, it will be edematous and hyperemic. The fellow eye, you can see a shallow AC as well as an occludable angle. These are the signs you have to thoroughly look if a patient comes with a red eye, so that we can differentiate between other red eye conditions. So what is the initial medical management of acute episodes? As you see that we have to immediate goal is the treatment is to relieve the acute symptoms and decrease the IOP. What should you do? Oral or topical harmonic anhydrase inhibitors can be given. Beta blockers, alpha agonist can also be given. In the patient where angle closure is thought to be secondary to pupillary block or plato iris, cholinergic agents like pilocarpine can be given. Evidence should be started after the IOP decreases to less than 40. Pilocarpine at a dose of 2% QID to the affected eye and 1% QID to the fellow eye is also to be given. Cholinergic agents have a paradoxical effect. In what type of cases? Lens-induced mechanism or aqueous misdirection, that is malignant glaucomas. We should not give this cholinergic agents. So we have to, it is contraindicated. If these medical managements are unnecessary, unsuccessful, hyperosmotic agents should be used. So, patient should lie in a supine to allow the lens to shift posteriorly if that is the cause. And we can start on acetazolamide 500 mg orally, that is 5 to 10 mg per kilogram. And if there is no vomiting, or if there is vomiting, we can start on IV mannitol as well as 50% glycerol at this 1 to 1.5 gram per kilogram. And topically, we can start on prednisolone or dexamethasone QID if there is AC reaction, and Timolide if there is no contraindication. Analgesia and antiemetics are also required. The following resolution of the acute attack, definitive surgical treatment is to be started within 24 to 48 hours with the aim of achieving a persistent open angle. These are the temporary measures that we have given. Now, we have to give a permanent. What is the method? We can give a laser iridotomy or iridoplasty after clearing the corneal edema with glycerol. Surgical options resistant to cases include even lens extraction, goniosynoculitis, trabeculectomy, and cycloablations. So, what are the findings suggestive of a previous episode of acute angle closure? Descending membrane phones, fine epithelial granules, corneal endothelium, glaucoma flecken, and there may be even a visual field loss. Coming to the PSCG. PSCG is untreated. Its angle is abnormal in function as well as in structure. Then coming to the chronic angle closure, visual acuity is normal unless damage is advanced. There will be peripheral anterior synechiae in these cases. The treatment options, primary option is acetazolamide at this dose, betaxolol, brinzolamide, dorzolamide, libubutanol. All this we can add, and an adjuvant therapy we can add like previous one, glycerin or even mannitol. Laser PA in the affected eye we have to do. And coming to the treatment in case of residual angle closure after the laser PI, what we have to do? We have to add on a prostaglandin analog for it. These are the other options. And lens extraction. If residual angle closure is there, lens extraction surgery should be done. Absolute angle closure, painful blind eye, we have to go on with a cycloablation. Thank you.
Thank you, Dr. Soumya, for that very informative talk. Now we can have a few questions. Dr. Irshad is there? No, in the case of a penetrating injury, once we suture the cornea, what is the role of intravitreal antibiotics regarding, say, medico-legal conditions and all? You give it routinely or?
So intravitreal antibiotics are actually not routinely indicated in a penetrating injury. So according to the type of injury and according to the contamination, one can decide whether we can give a prophylactic intravitreal. So routinely, I think no one is giving intravitreal in all penetrating injuries.
Intracameral anyway we are giving.
Intracameral routinely nowadays you are giving prophylactically even in all phacoemulsification also. So it can be given intracamerally and topically. It's okay after the closure of the wound.
After the closure of the wound, what about the anterior chamber wash, hyphema wash?
Should be,
When it can be done?
So after the primary surgery, actually we wait for the hyphema to clear. If the IOP is normal and otherwise as is okay, we can wait for long term, no issues. But if IOP is not controlled, if IOP is very high, like normal hyphema, like IOP is more than 50 for 5 days or 6 days, if we suspect any corneal blood staining or it can induce any optic nerve damage, definitely we may have to intervene again. Otherwise,
As
we
early
can
as
wait
possible.
as early as possible.
And there is a chance of secondary bleeding, na?
Yes, definitely. There's a chance of secondary bleeding even with a penetrating injury also. But most of the time we manage conservative only, because again entering the anterior chamber, again inducing inflammation is also a double-edged sword. So always better to wait and watch. If definitely it is going to damage the optic nerve or leads to a blood stain, we may have to intervene.
Thank you.
Thank you.
And Dr. Aisha, what about the role of oral steroids in chemical injury?
Normally, initial days we don't give any oral steroids because already to reduce the inflammation we are giving tetracycline or a doxycycline. But any patient who has a previous history of any steroid-induced glaucoma, where the topical steroids can't be given, we can consider about the oral steroids.
And Dr. Rishad, one more question. In the case of a chemical injury, which you have seen, if there is significant amount of epithelial defect, is there a role for immediate AMT, amniotic membrane transplantation? If we do it early, any significant advantage out of that? Early case.
Nowadays we see a severe chemical injury with limbal burns. We always start with the empty only. Empty usually we give
For medical management only, immediate only we can go for AMT.
yeah, definitely. Even though epithelium heal with a conjunctivization, if you put an AMT, it is very easier to remove the pannus as a whole. So once you plan for a later surgery with a SLET, if you did an AMT, the removal of the pannus will be much easier if the primal setting we did with the AMT. Otherwise, it is difficult to once the epithelium will be difficult and the later surgery also will be difficult. So whenever you have an access to an AMT in a grade 3 or more injury, always better to go ahead with the AMT. What I think so.
What I would say is, like, if a patient, you have to call the patient for a close follow-up. If epithelium is not healing after 5 or a 6th day, the persistent epithelial defect is there, so better to start AMT that time itself. We don't have to wait for the complication to come.
Okay, thank you. With that, we come to the end of this session. Thank you all the speakers.